So let's continue here with our case. So now we have our 31-year-old female. She received her 30 cc's of lactated ringers. She is a negative fluid responder. She's on 20 mics of norepinephrine and vasopressin at 0.4 and 0.04. And we have a MAP of 55. Her repeat lactic acidosis is 5. And I note just here that if you have a lack of clearance greater than 20% at 4 hours, this is a bad sign. Someone's not clearing their lactate. So her respiratory failure is worsening, and the chest x-rays shows increased pulmonary edema. She's on 50% FiO2, but her urine output is starting to decrease. So the ICU nurse notifies us. So what's our plan? So what we do is we can either put in a traditional PA catheter, or we can use some non-invasive measurement devices that are now available. We happen to use the NICOM. And what we show is that the SVR is 1150. Keep in mind here that a normal is about between 800 and 1200, but the cardiac index is low. It's 1.4. For our purposes here, let's just consider a normal would be about above 2.8. So again, we're going to use our echo skills, and our bedside echo is consistent with the cardiac index of 1.4. It shows an ejection fraction of 25%, but it shows some spontaneous echo contrast in the bilateral atria. What's that saying? It's saying that the blood pumping is so poor in the heart that the blood is starting to have some stasis, and we start seeing it as spontaneous contrast. And the ventricles show some cardiomyopathy, again, consistent with that cardiac index of 1.4. We happen to also get a mixed venous O2, and that shows 50. Normally, we would think in this context, maybe a normal would be between 70 and 80 or so. So with this presentation, which vasoactive agent would be best to improve cardiac function with these hemodynamic profiles? So here, let's talk about Dobutamine. Before I go into the right column over here for some of the information, let's take a look over here. Well, Dobutamine is really a primarily beta-1 agent with some beta-2 effects. And so beta-1 is going to give us our increased inotropy and some chronotropy, but mostly inotropy. And the beta-2 effects could lower blood pressure a little bit. And so that's what we see over here, right? When we turn from Dobutamine, go out here, we see increased cardiac output. We might have some decrease in SVR. So over here, just to be complete, so we usually start Dobutamine at a low dose, say maybe 2 mics per kilo per minute, and we usually can titrate it, up to about 10 mics per kilo per minute. Now you can go higher than this, and it's very common to go up to 20. However, when you start going past 10, you might see some more of the cardiac complications, such as maybe some more of the arrhythmia effects. So keep in mind that this can be a vasodilator. And so you could get some decreased SVR. And because of that, you might have to increase your norepinephrine drip or have some other pressors on board. So again, it's a beta-1 receptor agonist that increases cardiac output. Again, inotropy and chronotropy, heart rate can increase. Its exact role in sepsis is not clear. Though this was originally used in the RIVER protocol, now it's unreally clear when to use it. But it could be useful to improve cardiac output when the index is low, let's say less than 2.5 or so. Now, this is a catecholamine, and so it doesn't work well with a pH of less than 7.2, as all catecholamines, right? You see the trend here. And again, I'll repeat that because of the beta-2, you can get some of that hypotension, and you could get some arrhythmias, really mostly kind of atrial fibrillation. So here, what could be the role of epinephrine in our current case presentation? Well, let's take a look over here. Here I'm going to bifurcate epinephrine into low and high dose. And so here I show low dose. This is in the mics per kilo per minute measurements. But let's say if we're going to use mics per minute, this would be maybe like 1 to 3, and down here would be maybe 3 to 10 or so. And so when you start off with low dose of epinephrine, you're primarily getting really the beta effects, so beta-1 and beta-2. Keep in mind here that you do get beta-2, and it could be confusing to some individuals that when you start an epinephrine drip at low dose, say 1 mic per minute, you could actually get hypotension because of that beta-2 effect. However, as you increase the dose, of epinephrine, it becomes an extremely potent alpha agent. You still get your beta 1 and some beta 2 effects, but it gets extremely alpha. And so you're going to override any beta 2 effects here in reference to the use of epinephrine because of its strong alpha 1. So let's take a look over here now. So it works both on the alpha and beta receptors, though its effect on which receptors is dose dependent, as we just talked about. Again, at lower dosages, it works more on the beta receptors, as we talked. At higher dosages, it's a very powerful alpha-1 agent. And this is really why it's the go-to agent ACLS. It's such a strong alpha agent at high dosages. When we push that, 1 milligram during a code, we're getting such a huge return of blood back to the heart, and that's its role. Its role is not to restart the heart. Its role is to squeeze the arterial and mostly the venous tree in that situation to get more blood flow back to the heart to get it to start again. Now, it's a catecholamine, so that means, again, with the trend, it's not going to work well with a pH of less than 7.2. And the dose range is the same as norepinephrine. It's about 0.1 to 0.5 mics per kilo per minute per the ACLS guide and sepsis guide. Now, this is interesting here. With epinephrine, because primarily it's beta 2 effects, we really don't get this with dobutamine, though you get some beta 2 effects. But with epinephrine, because of its beta 2 effects, you could get some increased lactic acid. And so it might be difficult to trend, lactic acids at this point in time. And the elevation in the lactate, again, due to the beta 2, comes about because the beta 2 effects, primarily in skeletal muscle, its stimulation upregulates glycolysis. And when this happens, you end up generating more pyruvate than can be used by the cell's mitochondria via the TCA cycle. And so what happens is that the excess pyruvate is then converted over into lactate. This is not necessarily a bad thing if the lactate goes up. This is happening for other reasons, again, related to that glycolysis. So not trending lactates anymore or not putting as much weight is something you have to keep in mind. So again, because this is going to have both alpha and primarily beta 1 effects right here, I mitigate the beta 2 effects because the alpha 1 is going to override. This could replace norepinephrine and dobutamine combo. And then again, since you're going to get that strong beta 1 effect, you usually consider not using this with dobutamine, but sometimes you do use them concomitantly as well. So is there an alternative inotrope to dobutamine in cardiogenic shock? And there is, milrinone. So let's take a look down here. So milrinone is even more really of an increased cardiac output agent, but it's also even more of an decreased SVR agent as well. And this is a more of a unique medication. So milrinone can be used as an option in cardiogenic shock. Again, it's not a vasopressor because it's going to decrease SVR. This works via the second messenger in the catecholamine pathway. Primarily, that second messenger is going to be cyclic AMP by acting as a phosphodiesterase inhibitor. So phosphodiesterase is what breaks down the second messenger for catecholamines, which is cyclic AMP. And by not breaking down cyclic AMP as much, you increase it, and you have that, in essence, intracellular catecholamine effect. And this could be used and manipulated in situations such as maybe beta blocker overdose, etc., by knowing about this. But again, it increases cardiac index, but you're going to lower SVR. So you're going to get that, you have to monitor your blood pressure when used. Like dobutamine, whenever you have some of these beta 1 effects, and this is just really an intracellular beta 1 effects, you could get an incidence of arrhythmias. And so you have to be mindful of this. But now this medication is interesting, as when we talked about vasopressin, we talked about how there was no V1 receptors on the pulmonary vasculature, so you wouldn't increase your pulmonary vasculature with use of that drug. However, this medication actually decreases pulmonary vascular resistance. So as maybe some anesthesiologists who have done liver transplants know, it's common to use this medication in liver transplantation because when you put in the liver, you get this huge increase in blood flow that's going to come to the lungs. And you can use this to help the lungs accommodate that extra blood flow by lowering the pulmonary vascular resistance. And likewise, we might use this maybe in unique cases in sepsis if we have individuals who have very high pulmonary pressures and right ventricular failure or otherwise. This might help. So we can keep this in mind. So What about dopamine? Here, I'll bring your attention to the chart. It's kind of somewhere in between really the SVR and the cardiac output effects. And here it talks about low and high dose, but I actually talk about 3 doses on this column over here. So keep in mind that dopamine is converted in our bodies to norepinephrine. That's the normal catecholamine pathway. And so it makes sense that as you get the higher dosages, what you're really using is more of a levo-fed type of agent, but you still actually get some more of the increased tachycardia. So let's review here that there is a dose-dependent effect. And though there are numbers here for illustration and teaching purposes. Keep in mind here that people have wide variances in pharmacokinetics. And so these numbers are not set in stone, and they're usually more for teaching purposes and as like general trends. So at dosages of 0 to 5, you work primarily on the dopamine receptors. And you're going to get some increased tachycardia with this. So at dosages of 5 to 10, you have beta-1 receptor effects. So again, some increase in chronotropy and some inotropy. But then at higher dosages of 10 to 20, you get some of the stronger alpha effects, and likely because some of that dopamine is being converted, or a lot of that dopamine is being converted over into norepinephrine. So what about our surviving sepsis guidelines? Well, really the only recommendation in the surviving sepsis guidelines for dopamine is going to be patients who have bradycardia. And maybe if you tried norepinephrine and their bradycardia gets worse, then it's reasonable to consider this agent. However, keep in mind that several studies have shown higher mortality in meta-analysis with dopamine use due to cardiac side effects at high dose. And so again, this is why it's no longer considered a first-line agent. So what about phenylephrine in refractory shock? I mean, as any critical care anesthesiologist might talk about, phenylephrine is, ubiquitous in the operating room. We use it every single day. And it's probably our go-to medication to increase blood pressure. And that's because primarily the agents we're using in the operating room decrease SVR so potently. So things like propofol and things like our volatile anesthetic agents. And so this is a one-to-one antagonist to what we're doing in the operating room. So what is phenylephrine? Phenylephrine, as we see over here, dramatically increases SVR, but it could decrease cardiac output. So why is that? Well, it's a pretty much a pure alpha-1 agonist agent. And in sepsis, there's really no data for it so far, and it's not really mentioned in the surviving sepsis guidelines, and there's even no expert opinion out there. So again, being a strong alpha-1 pure agent, what do you get? You can get some reflex bradycardia. And then again, really at higher dosages really of almost any of the catecholamine pressors we use, you can get some risk of bowel ischemia and maybe ischemia of the myocardium as well. What would higher dosages maybe be considered here? Maybe greater than 100 mics or so per minute. Usually when we use this medication, we see the dose down here, we run it between like maybe 0 and 200 or so. Again, it's a catecholamine, so it doesn't work well when you're acidotic with a pH less than 7.2. I talked about how it's widely used in the operating room, and so anesthesiologists have a great familiarity with it. But again, knowing your pharmacology very well, you use all this information to your advantage. And so you can bolus phenylephrine at the bedside, say anywhere from 50, maybe even always up to 400 mics at a time. What are you doing here? Maybe if you're going to intubate a patient and you're going to use propofol for induction and you're going to drop their blood pressure with the propofol, you can chase the propofol during induction with phenylephrine. And they have pretty much about the same half-lives or so. Phenylephrine's a little shorter. You might have to repeat a dose. But you can mitigate some of those hypotensive effects. Again, so knowing the pharmacology here could be very useful. But in terms of sepsis, we really kind of don't quite know right now. Just for completeness sake, I wanted to mention isoproterenol, just in case if someone came across of it. So isoproterenol is known to anesthesiologists because it's widely used in the electrophysiology lab. But why? It's used in the electrophysiology lab because it induces arrhythmias, and we want to know where the source of the arrhythmia is, and so to help our cardiologist colleague find it, and so they can ablate it. So it has both beta-1, where you're getting most of that arrhythmia effect, but the beta-1 effect gives you some inotropy. and beta-2 effects, but it's pretty much 50-50, beta-1, beta-2. And so with a strong beta-2 effect, you're gonna drop your blood pressure. And like back in the day, we don't use it anymore, but it was used for heart block, and it would be hard to find a time that we would use it now for heart block, but maybe. I don't know when that would be, but it's important to know the pharmacology. But there could be some select instances to where maybe we would use it, and so it's important to know about it. And maybe some of those instances maybe would be something like aortic regurgitation. So there, by having an increased SVR, you might have increased backflow back into the heart because of the regurgitant valve. So perhaps having an increased squeeze and decreasing SVR could encourage forward flow and actually improve your hemodynamic profile. So again, it's important to know the pharmacology here, because by knowing it, there could be select unique cases where you might decide to use it. So now let's start to gently move into some of the refractory shock areas and like, what are some of our other options? And so let's take our case again, where we have a 31-year-old female in septic shock. She received her 30 cc's of fluid bolus. She is not fluid responsive, meaning that giving fluid would only increase, could possibly increase more mortality in this instance because she's not showing a response to it. Norepinephrine's at 30 mics a minute. Vasopressin's at a very high dose of 0.1. She's also on epinephrine at 20 mics a minute. Her MAP is only 45. She's beginning to become oliguric, and her fingers are turning bluish. Lactic acid is now 12. So again, she's on the epinephrine, so I'm not really quite sure what to make of that lactate, but a lactate acid of 12 is still high, regardless if you're on epinephrine or not. So it's important here that though we're a specialist in critical care and we know a lot about many of the different fields, when we get into these difficult cases, consider calling our cardiologist colleagues for support here, because it's important to get different perspectives. Because again, there aren't strong guidelines here, so different perspectives could be helpful. But are there any other options per the surviving sepsis guidelines? Not really. There is some talk about maybe low-dose steroids, hydrocortisone. It's level C data. The benefit is lacking. I'll talk about it a little more in the next slide. Also during the next slide, what about the HAT trial by Paul Merrick? A lot of enthusiasm about this, but keep in mind it was only 63 patient study, non-randomized. And on the next slide, we'll talk a little about hydrocortisone, again, as above, thiamine and vitamin C. And I'll leave this here for when I talk maybe about on the next slide with vitamin C and thiamine. I'll go into it more depth there. But what about maybe angiotensin II inhibitor? So here we have Giopraza, a new agent that could be considered. So let's turn here to this slide. So what is this slide? Where does this come from? This comes from, about a year ago now. Chest came out with a paper and reviewed refractory shock options. And these were pretty much the options that were given for consideration, to where you're at the end of the rope and you're not sure what to do. So let's review some of these one by one in detail. So the first one here is going to be hydrocortisone. So per the Merrick trial, the common dose that was used was 50 milligrams Q6 hours. People also use this maybe 100 milligrams every 8 hours. And what's thought to be possibly the benefit here? So an increased vascular catecholamine response. And that's why people possibly consider using it when you're already maxed out on 2 pressors, or you're on 2 pressors and you're getting close to maxing out, to increase the response to the catecholamines. I'm going to skip calcium for now and I'll come back to it. I'm going to continue with some of the Merrick protocol medications. What about ascorbic acid? And so in the Merrick trial, a dose of 1.5 grams was used every 6 hours. And what was thought maybe could be some of the possible effects of the vitamin C? Why might this be effective? Well, vitamin C is a cofactor for catecholamine and vasopressin synthesis. And so you have increased endogenous production of your catecholamines during a time when you really need them. We talked about how sepsis is an acute inflammatory response, and you have a high level of free radicals being produced. And vitamin C can act as a free radical scavenger, and it's thought that maybe that might help. Also keep in mind too, vitamin C originally, when we talk about it in the medical literature, is for things like scurvy. And what's scurvy? Scurvy is a breakdown of your capillaries, which causes bleeding, say maybe in the gums. And so vitamin C supplementation can help collagen synthesis, particularly here we're referring to now the capillaries, and maybe you can have decreased capillary leak. So these are some theoretic concepts. What about thiamine here? Well, thiamine in the MARC protocol was used at 200 milligrams every 12 hours. And thiamine here could be used to increase the clearance of lactate. So there is some debate about maybe whether or not lactate might actually be beneficial in sepsis. That's kind of beyond this talk. But here, by improving lactate clearance, at least for the MARC trial, it was small, there was a benefit. So let's say if we placed our patient on the MARC protocol, so they're on the hydrocortisone, the vitamin C, and the thiamine, and we're still not getting a response. What now? Some simple things could be a sodium bicarbonate infusion at 1 to 2 milligrams per kilogram bolus, or run it as a continuous drip. And so what are we trying to do here? Reverse metabolic acidosis. One of the concepts here that we repeated multiple times in this talk is that our catecholamines don't work well in an acidotic state. And so we can use bicarbonate here to try to not have an acidotic state. Though I do not believe that this is available, at least it's not available in my hospital anymore. One thing, I'll talk about THAM in a second. One thing that happens with bicarbonate is that bicarbonate gives off CO2. And so you might see that if someone's mechanically ventilated, which these patients will commonly be mechanically ventilated, you have an increased CO2 production, and you might have to increase their ventilatory rate to prevent acidosis from happening, this time secondary to hypercarbia. However, THAM is an agent that if available, could be considered to be used in that it can reverse metabolic acidosis, but it doesn't give off CO2, so you don't get that hypercarbia. So if that's a problem with your ventilator, this would be a consideration. What about continuous calcium? And so this could be an option here. So calcium can bolus 1 to 2 grams at a time, or continuous infusion ran at 20 to 50 milligrams per kilogram per hour. And here, this is thought to increase vascular calcium signaling. So now let's get down to maybe what I find some more interesting agents. Let's bring our attention here to methylene blue and hydroxycobalamin. For some, maybe this might be the first time we're hearing about this. For some of us who practice anesthesia, and particularly cardiac anesthesia, we might have had some cases of individuals coming off pump in the operating room, and they became vasoplegic due to post-cardiopulmonary bypass syndrome. And here, there are some case reports out there of using methylene blue to reverse this major vasodilated state. And because of this, some individuals had the idea to use it in sepsis. And so what is methylene blue? What is its mechanism of action? Well, it's a nitric oxide scavenger. And in some individuals with that distributive shock state, part of their distributive shock is a dysregulation maybe of nitric oxide, and that's causing that massive vasodilation. And so methylene blue can be used to scavenge nitric oxide. I have now used this about over 100 times, and I personally now have had effects in about at least 75 of those patients, and some of the effects have been dramatic. I've had some patients that were on 3 pressors maxed out, and by the morning they were only on norepinephrine at a medium dose, so really a dramatic response. I also had some cases in which it didn't work for some individuals. But this is methylene blue, and this is the dose here, bolus and then infusion that it could be used at. Notice here that this is This is a titratable dose down here, and this could come in handy because oftentimes you might have to go back up on methylene blue or down, etc., as you would a pressor. So what are maybe some of the concerns in methylene blue? There's concern for possibly serotonin syndrome, maybe increased pulmonary hypertension, and then really because of the increased pulmonary hypertension, maybe some hypoxia. I personally haven't encountered this, but again, if I've only used it maybe a little more than 100 patients, maybe I just haven't used it enough to encounter some of these complications. What about hydroxycobalamin? So hydroxycobalamin, again, is a scavenger of nitric oxide. Here, this is methylene blue. It's an inhibition of nitric oxide and scavenging. Hydroxycobalamin here is a scavenger of nitric oxide. The recommended dose per the current literature that people have out there is a one-time dose of 5 grams. I have used it maybe about now between 10 and 15 times. I've had more success maybe with methylene blue, maybe because it's titratable. And I've needed to titrate it to get the maximum effect. But this is extremely convenient where you just give one dose, 5 grams. And oftentimes it's difficult for your hospital maybe to get as much methylene blue as you need to run. And so this is an option to consider. Now with both methylene blue and hydroxycobalamin, even though it only says interference with hemodialysis sensors here, whenever you're giving something that enters the blood that has a color, you could have some difficulties with the pulse ox, particularly with methylene blue, because you have 2 wavelengths of red for the pulse ox, and the blue could really interfere with it. And so it could be difficult. You need to let your nursing staff know that the pulse ox might not be accurate. You might have to work, just use ABGs. But again, you could get some similar problems here with hydroxycobalamin, and you can have some interference with the hemodialysis sensors. And then I'm not really going to talk about here telepressin here because this talk is geared towards the United States audience and it's not available. But down here we talk about the angiotensin II again. And so there is a starting dose and a dose range to use here. And it's an angiotensin II receptor activation. This I'll talk about here a little bit more on the next slide. So this here is angiotensin II for the treatment of vasodilatory shock, promise and caution. And so this is exciting whenever we have a new mechanism for a drug. So it works, angiotensin II works on vascular-smooth muscle. This particular paper here from the New England Journal of Medicine was 344 patients with distributive shock, and they measured increased blood pressure at 3 hours with stable pressor dose. And this was potent and effective vasopressor. But there is caution here to use this in patients with low cardiac output, and patients with low cardiac output were excluded because it's primarily just increasing again that SVR. And since there's no compensatory increase in cardiac output, that increased back pressure could be deleterious to the heart. It's expensive, as most new drugs that come on the market when they're currently patented. Again, there's caution to be used. If someone's cardiac index is maybe, let's say, less than 3 liters, you could have increased mortality because of that. There's concern for increased thrombosis. Currently not recommended to be used as a first-line pressor, and really we need more experience with the drug to have a better understanding of where it might fit in. So this last slide here is really more for fun. And it's to mention just concepts that when there are no guidelines, as anesthesiologists, we know that we have to know our drugs extremely well, and we have to know physiology extremely well to try to think of ways maybe to keep our patients alive when there aren't, again, guidelines and guidance out there for us to use. And so here I'll talk about Precedex. And so most of us, when we think of Precedex, we just think of it as an alpha-2 agonist. That's it. There are actually 3 different subtype receptors for Precedex. There's alpha-2A, alpha-2B, and alpha-2C. Now, alpha-2A and alpha-2C are presynaptic on those norepinephrine receptors in our body, on the sympathetic nervous system. And when we activate those, you have a decrease of norepinephrine being released. So you inhibit norepinephrine production, and that's maybe what could give rise to your bradycardia and maybe some of your lowering of your blood pressure. However, that's presynaptic response. Alpha-2B is postsynaptic, and at higher dosages, Precedex works on alpha-2B receptors. And what is the effect of alpha-2B on postsynaptic? It directly activates the postsynaptic neuron, just as norepinephrine would. and you get vasoconstriction. And here, I show this here with higher dosages. So you get with lower dosages here when you originally use it for mean arterial pressure, you get that maybe bradycardia, and you get some of that decreased SVR and lower blood pressure. At higher dosages, you can actually increase your mean arterial pressure. And what's that inflection point? That inflection point could be about 2 mics per kilo per minute. And it could be used in the ICU up to 2 mics per kilo per minute, or maybe even 2.5 mics per kilo per minute. And so you could see this response. However, I want to emphasize here, as the blood pressure goes up, you still have the persistent bradycardia. So caution has to be thought about for the heart. And again, I'm not necessarily recommending this. I'm using this as an example that it's really important for us to know our drugs, because again, when there are no guidelines, knowing our drugs and knowing the physiology could maybe be the difference for us saving our patient. And if you like this presentation, I wanted to bring your attention just to our website. If you're not watching it on our website, we have many more free videos, and I would encourage you to come here and to please watch some other videos that might be of interest to you. Thank you.